I address my patients who have memory problems through a trauma lens, just the same way as people who come in and say, I'm really struggling. My whole family's cut me off and I'm not sure what's happening, but there must be a pattern here. Can you please help me?
Welcome to the Evolving Past Alzheimer's podcast, where we are focused on bringing you information to help prevent from developing and improve from suffering with brain diseases like Alzheimer's and other dementias. I'm Dr. Nate Bergman, a physician and Chief Scientific Wellness Officer at Kemper Cognitive Wellness, and I'll be your guide on these sound waves. So whether you're a baby boomer who's worried that your brain wiring just isn't working like it once was, or you have a loved one with the disease, or you yourself have already been diagnosed and are wondering, what do I do now? You'll want to listen to this podcast. Each episode, we introduce you to the top doers and thinkers that are revisioning Alzheimer's, dementia, and just generally things in life's second half. If you have questions or comments, check us out on social media. To support us, go to patreon.com/evolvingpast and consider hitting the button and becoming a patron of this show if you find these episodes valuable. That's Patreon, Patreon, patreon.com/evolvingpast. So here we go. Let's get better. Welcome back to the Evolving Past Alzheimer's podcast. I am Dr. Nate Bergman, and again, we, as always, thank you for listening. So, trauma seems to really have emerged on the world stage, certainly to those of us that are in the United States since the events of 2020, and now more than halfway through 2021, we're reading about burnout and anxiousness and anxiety and PTSD, and even, suicide over the years. And for those of our listeners that are either suffering from or are care partners of people facing diagnoses like Alzheimer's, other dementias, suicide for some, and maybe probably not most, but has definitely crossed their mind, right? And so this episode kind of is somewhat a lead-in to future episodes where we want to look at how the nervous system, our brains, are informed by trauma. So trauma-informed medicine, trauma-informed psychotherapy. Many of you might have heard of this, though it's been around for a while. It has, again, emerged with a more prominent role and position since the events of 2020. But clearly it's playing a role in cognitive impairment, Alzheimer's, and dementia. I personally feel like it's been underappreciated. And when I found a colleague who is part of our study group, who I've known now for a few years, presented this concept in a manner that she didn't even know was so relevant and so prescient to me personally and many of my patients, I was very, very excited to have her on. So I want to introduce our very special guest for this episode, Dr. Ilene Naomi Rusk. Dr. Rusk completed her PhD in psychology, neuropsychology and psychopharmacology in England, and fellowships in neuropsychology. She worked collaboratively with the pharmaceutical companies and has authored peer-reviewed articles on brain and behavior relationships. Basically, she's dedicated her career to studying novel treatment strategies for Alzheimer's disease, and she sees trauma as a root cause of many illnesses. Professionally, she's also co-founded the Brain and Behavior Clinic over 25 years ago and directs the Healthy Brain Program in Colorado, where she lives. Welcome, Dr. Rusk.
Thank you so much, Dr. Bergman. It's really nice to be here with you.
Okay, we'll get official.
Then we'll get unofficial.
So yeah, quickly. I first started thinking, I think, more critically not too long ago, maybe 2015, 16, before you and I had met. But when we were already starting to see a lot of cognitive impairment patients, and, you'd already done the geriatric stuff and got on board with functional medicine and Dr. Dale Bredesen's work and his sort of hypothesis and ongoing kind of theory, where I had my first patient present looking for that kind of approach, kind of a functional medicine approach. And it was very clear that trauma was a important root cause or co-contributor to what was going on with her in terms of her cognitive impairment. This woman was like in her late 60s, had fairly advanced dementia by that point. It really made it difficult for her to do anything other than kind of get up and go to the bathroom, maybe shower, get dressed, eat food that was prepared by her husband. But it was very clear that childhood trauma had been a big driver of what was going on. And I was sort of and I talked to many psychologists that I knew, some neuropsychologists that I knew at the time, and was like, how do we treat a woman that is sort of so advanced, right? Like where it's clearly playing a role, but we can't do like cognitive behavioral therapy. We can't do sort of the usual talk therapy that we think of with kind of adults and adolescents and children, certainly. So I I just wanted to kind of start with that story. I know it was a lot, and we haven't heard from you yet. But can, I've used the word trauma several times already, and I haven't yet defined it. But I'm excited to have you on. Can you kind of just, for the rest of the discussion, to frame the rest of this discussion, what do we mean when we say trauma? What does that mean?
Well, Nate, I'd like to define trauma. I also want to speak to the story that you told because later on in our conversation, I hope we talk about the benefits of some of the cognitive strategies that we use therapeutically, like cognitive behavioral therapy, and maybe talk about some of the limitations of those cognitive strategies for patients who have cognitive impairment, but also for everyone else who is interested in some of the newer modalities that might integrate cognitive strategies with somatic techniques, more embodied techniques that include the body's wisdom and the body's information in healing some of what it has stored as trauma or traumatic imprint. So I'm happy that you mentioned your patient because I'd love to talk about her as well as an example. In general, trauma can be defined as any event, any occurrence that we process, react to, remember, or not remember, but something that overwhelms us, that overwhelms our nervous system. It can be a persistent irritant. It could be a serious event like a car accident or a blast injury, or it can be as subtle and long-lived as a toxic marriage. And trauma leaves imprints in the mind, in the brain, actually, and in body somatic patterns. I like to define trauma, and many of my teachers and mentors define trauma as well as an event in which a person feels unsafe. And I think the key word here is helpless or defenseless.
Mm-hmm.
It's a situation where we haven't had the chance to engage our defensive response that allows us then to feel safe again and settle.
So that's a really excellent. And I want to highlight something that you said there because the way I've been saying it is the sort of like the brain is in the body. We sort of think brain, head, and mind and thoughts. And you mentioned the word embodiment, which we will unpack, I think, in later on in this conversation.
Mm-hmm.
But do you agree, sort of this, that it's helpful to maybe consider that our emotions, our thoughts don't just happen sort of in our brain, but they're stored, lodged, and also have an influence, trauma, etc., have an influence on everywhere our nervous system is, including influencing our hormones, our immune system, our GI function, etc., things like that.
That's
Like
right.
meaning it's a sort of a big network.
Mm-hmm. Trauma, I completely agree with you, and trauma impacts. Um, I was reading about the vagus nerve last night. Trauma primarily affects areas in the brain which control, autonomic or basic functions, survival impulses. So you're right. Um, Trauma impacts digestion, our sleep-wake cycle, our immune functioning, the permeability of our gut, our breathing, our heart rate variability. So
All kinds of
imagine a
things.
thought, imagine a distressing thought. And for your listeners, I invite them to not imagine this thought that's too distressing, but kind of a moderately upsetting memory that they might have. So pull up like a moderately upsetting memory, if that's not too odd a thing to ask. And then just notice what happens to your body. When I pull up a mild or moderately distressing thought, just a pure cognition, I notice that there's a resonance or a reverberation in my body, even if it's just a little, even if it's just slight. So I think there is this constant feedback loop. It's like an infinity sign back and forth from the brain to the belly to the blood vessels to the heart rate. So I don't think you can separate. It's very true. You must see that with your patients, though, that there's this very tender connection between what their cognitive complaints are and what their somatic complaints are, that it's really difficult to separate sometimes.
So I totally, I would say, I don't know that I always did. I think maybe intuitively I relate to my own body,
Yeah.
perhaps more than some of my close friends that we can have conversations like this about. However, when a patient comes in, to an MDDO kind of a person, as opposed to maybe what you do, and I do really want to get into how you got into what you're into now, as opposed to, let's say, a therapist, a psychologist, or certainly a neuropsychologist. Um, they sort of are. My sense usually is that they're looking for the doctor to tell them the answer or the thing that's going to fix them, and 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 when I kind of put things back on, well, have you considered these other things? Sometimes that's a little disarming, and I will say there are definitely people that are open to it, and there definitely seems to be people that are like not open to it, at least not at first pass, right? But some of those people, with time, depending on how they do, they 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 do open to it eventually. Um, can I ask you though, because you have maybe, I don't know if it's a traditional or non-traditional like kind of approach. How did you get into starting what you're doing now in Colorado, which you've been doing now for 25 years? Like, you didn't just start at the level of, okay, trauma is a big deal.
No, I actually think I started, the more I reflect, I think I started with, and thank you, by the way, for being one of the clinicians. I think you were the first clinician I met after training with Dr. Dale Bredesen, who was so sensitive to people's nervous systems and how the tone of the nervous system or the health of the nervous system or the baggage that people were carrying, traumatic baggage that people were carrying, impacted their cognition, their Alzheimer's, the neurodegenerative issues that they were coming to clinic with. You were actually it felt like you were an oasis for me when I first met you. So thank you very much. Nate, I started with my own difficulty, with my own trauma. I started not knowing that I had trauma, but when I was quite young, in my teens, my mid-teens, I developed all of these symptoms, these very complex neuropsychiatric symptoms. It's not something I usually talk about, but I was very focused on cognitive changes and physiologic changes. And I started a deep study of the relationship between mind and body. I saw a psychotherapist, actually a psychiatrist at that time, and that's when I started trying to understand the relationship, the tender relationship between mind and body, brain, and peripheral physiology. And so I started on my own journey, and it was a journey that started because of fear. I had my own fears, and I focused and ruminated about my own somatic complaints. And the reason I'm saying that is because it wasn't a
Can you
health.
just, I'm sorry to interrupt in the middle. The somatic complaints may not be a term that everybody's familiar with, even though you're in the middle of a really important story and point. Can you just say what you mean by somatic complaints?
Of course. I was noticing at the time that I had a lot of physical symptoms, a lot of twitches, a lot of muscle contractions, a lot of trouble with my gut, a lot of distraction, a lot of. Now I know that I was actually having periods of dissociation where I was cutting off from my real feelings because I had experienced trauma myself.
Yes.
So I was dissociating, but that was happening in an interesting way. I was focusing on my bodily complaints or my somatic complaints, thinking that they were neurologic symptoms. And I perseverated. I focused on those things. So I'm talking about that as an unhealthy way of focusing on the body. There are healthy ways to focus on the body and be embodied. But when you're in a place of fear and distress, those ways are not prominent. So I was not embodied at that time. I was working, as I like to say, from the neck up, very focused on my brain and my thinking and what I could do to solve the problem, not knowing that I had anxiety. It was really anxiety and fear based that I had to release and work with in a trauma informed way.
Right.
So that gives you a slightly more developed response to how did I get into this. And then I became a neuropsychopharmacologist. I became interested in those tiny molecules that could influence behavior. And I thought, wow, those were the days when we thought that those tiny little powders that we received from labs and pharmaceutical companies all around the world, that we would be able to change big behaviors with those single tiny targeted molecules. So I
Wow.
was working on Alzheimer's disease and Parkinson's disease, looking at the neurobiological substrates, trying to use the silver bullet, silver targeted strategy. And after many years, I think we've all figured out that strategy doesn't work. We need a more complex, layered root cause approach to understanding complex neuropsychiatric, neurodegenerative problems.
Mm-hmm.
So that gives
Definitely.
you a taste of where I came from with
Oh
all of
yeah.
this.
So at this point now, so you have a couple of decades. So I think at least I pay much more attention to someone who's talking, who's been in practice 25 years, than someone who's been in practice for 5 years, for instance. And at this
Yeah,
point, let's say someone comes in to your clinic with memory or cognitive problems,
yeah,
particularly if they sort of smell like something neurodegenerative, so Alzheimer's, Parkinson's, etc. Um, how do you first? How are these people finding their way to you? But once they find their way to you, um, how do you? What's your approach? Like, how do you? Is this like you treat them like everybody else, or is there something different about
yeah.
these
hmm
folks?
Uh, People sometimes self refer. You asked me where patients come from, but often the patients have either been, I would say, kind of neglected because other providers don't take their symptoms seriously, but I do. And I think that's because patients also come to our clinic with complex problems. They're not sure if they're emotional problems, psychiatric problems, neurologic problems. Um, Sometimes they come because they've had a traumatic brain injury and a concussive injury, and they want help teasing apart whether it's emotional, whether it's cognitive, whether their pain complaints are contributing to their cognitive problems. And sometimes people come in because they have a family member or many family members who have neurodegenerative disease, and they want a prevention strategy.
Right.
Often people come in with complex medical problems like chronic pain. Sometimes they come in directly for trauma support, but I'm always looking through a trauma lens. So I address my patients who have memory problems through a trauma lens, just the same way as people who come in and say, I'm really struggling. My whole family's cut me off and I'm not sure what's happening, but there must be a pattern here. Can you please help me? And I guess the commonality is I always look for uh, adverse childhood experiences that might have happened. I also really observe my patients, look at how they are right now, how they are in this very moment, whether it's in person or it's in the clinic or on Zoom or Doxy. When patients come in and say, I'm really worried, my mom has AD, Alzheimer's disease, it's different than um, someone who comes in specifically for trauma support or health of their nervous system. Um, so for the aging patients, I put them through a functional medicine brain health screening protocol.
What does that look like?
That's
In
that's
the
great.
general sense.
Well, I survey their cognitive symptoms. I ask them why they're here. I look at them, I see, are they coming with tension and fear? Are they relaxed? Are they frozen? Are they relationally connected to me? Are they tracking the conversation? So I ask them about their cognitive complaints. I ask them about their emotional complaints too, because so often the pattern of cognitive complaint gives us a clue. Of course, this is just a screening need. So I'll send them for a neuropsychological evaluation to look at areas of deficit and strength cognitively and look for patterns um, of strength and weakness in their cognition. And we can talk a little bit more about the domains that a neuropsychologist might assess with those patients. Because so often I see people who've had memory problems or have had attentional problems or executive function problems for so long, but they've actually never been evaluated,
Yeah.
which kind of surprises me. I'm like, so I
So
ask them,
that actually comes up a lot now, and
yeah,
this is it's again very prescient. The second time I've used that word,
that word.
um, because it just is so kind of timely. Attention problems, focus problems,
Right.
lifelong. Like I'm thinking of two patients, one of which I'm seeing next week, right? Where sort of lifelong, what we would call now ADHD, mid 70s, now with diabetes, trying to stay home by yourself,
Mm-hmm.
and just sort of the fires of Alzheimer's dementia are starting to rage in her. And like, there's so much fear and there's so much like and like we sort of just call this behavioral disturbance as part of like a normal or as an aspect, which it of course is, of dementia, right, or Alzheimer's dementia, like the I want to go home, or screaming for no apparent reason. And there are a number of different theories and approaches as to why this might be. But if you think about this person, or you think about the patient that I mentioned earlier, the 68-year-old woman who had a very very difficult childhood, and we can leave the terms like complex PTSD out of this because it may get uh, like too complicated. But for people that have had trauma or have never had, let's say, attention or the ability to sort of get things done or execute
Mm-hmm.
executive function, like you started to get into the domains of brain function, of cognitive function that you might look at. How do you, so can you kind of lay out, okay, these are the things that we typically look at. So other than memory, right? It's not just I can't remember,
Mm-hmm.
but word finding and like other things that someone like you is well trained in.
Mm-hmm.
So you're looking for what, and then kind of like, then what? Okay, so these are the issues. So we know, what did that tell you? If there's a problem with one thing versus the other,
Mm-hmm.
and of course it's nothing definitive, but what is that? What does that lead to once why are you asking those questions, and then the answers to those questions, it'll be different, obviously individual to individual, but how does that then lead to maybe next step
Next steps.
considerations?
Mm-hmm. Mm-hmm. I'm interested in your patient who's had lifelong attentional problems. You know, this is an aside, but having studied a little bit about ADD and ADHD, uh, because I have a son who had ADD, ADHD, and has worked through it, and he's given me permission to say this, by the way. I
Mm-hmm.
noticed that attentional problems, if they're not treated, do stay with people. And when I tell my patients when they come in that there's this very um, clear marital relationship between emotions and cognitions. And what you're speaking to is a woman who's dysregulated, probably was hypervigilant or couldn't focus her attention just on one thing because she was scattered and not safe. I mean, I'm really doing some interpretive dance here as you describe your patient. But when I hear about someone who really can't focus, has never been able to focus, yes, of course, there are dopaminergic and noradrenergic substrates to attention and neural regions which support focus and attention. But I also see that emotional dysregulation and inattention go together, are very, very closely related. And when we don't attend, and this is something I do with my patients who come into the clinic early on, I explain to them that there is this relationship between emotion and cognition, just as we discussed before, that you can't really separate. So if you can't attend and you can't focus your attention, then you can't pick up information. And if you can't pick up information, then it makes it more difficult to learn. And if you can't learn, then it makes it more difficult to encode information and then keep it and store it. And if you
So,
can't,
in other words, having trouble paying attention would lead to memory
problems.
memory
That's
problems.
exactly right.
Yeah.
So that's how inattention and memory problems are linked together. And with someone who has chronic inattention, it seems as though you would expect that they would have memory problems or consolidation problems.
What is consolidation mean?
Forming the memories and then being able to keep them. And after we keep a memory, we then have to be able to retrieve it and get it back to make it useful so that we can communicate about it in some way, either with somebody else or writing about it. So we've just gone through the whole kind of attention learning and memory cycle right there. And I do study those things when I talk to my patients, and I say, just let me know, do you have any trouble with paying attention or remembering names or conversations? How distracted do you get? I ask them questions in the categories of attention and concentration, in the categories of learning and memory, and in the categories of language as well. Do you have trouble either communicating? Do you ever say things you don't want to say? Or do you have trouble remembering conversations or names? We often have patients who come to us, Nate, who say, I was at a party, I just cannot remember anything anyone's saying to me. I can't remember, I see their face, I can't remember their name. And so those are some of the things that I ask about in terms of cognition. I also ask about driving when I ask about cognition, because driving requires so many cognitive skills. It requires attention and judgment. It requires executive functioning and reaction time. So it also lets me know, I once had a very, very interesting patient who had an early neurodegenerative disease, but her first symptom was she realized that she wanted to turn onto an exit off of the highway, but she wasn't able to. She couldn't navigate turning right. She knew she should, but she just couldn't make that right-hand turn. She couldn't make that visual spatial connection or decision. And she had a type of neurodegenerative disease that happens sometimes to people younger in life. I'm trying to think of the name of it. So I ask about driving, and then I ask about their emotional tone. What are they like now? Have they tended to be, depressed in their lives? Have they had difficulty understanding other people's feelings? Have there been problems with their ability to empathize? Has there been this pattern of depression or maybe overactivation or overstimulation?
Why are those
those are really
important
because I categorize those basically into three categories, and they're sort of nervous system categories in my mind, and in stress or trauma nomenclature. It's either sympathetic arousal, where people are very anxious, or sympathetically aroused, meaning maybe they get a little angry, or maybe they're a little more threatened, maybe they're a little bit more aggressive, maybe they have more anxiety or trembling. That to me is an arousal response. If people are more shut down, I tend to see them more in a parasympathetic or dorsal vagal collapse. And I'll just explain what I mean by that: a more shut down or freeze response. Sometimes people are depressed. They have very little motivation in life. They're kind of collapsed. You get a sense of their posture. They're kind of contracted and pulled back. That's right. Or you get a sense of an aroused, sympathetically aroused person who has reacted to trauma or reacted to stress or distress in a more, forward-facing, maybe aggressive, maybe anxious way.
Yeah.
So that's why I ask about mood. I also know that depression is one of the important signs and prodromal symptoms of many neurodegenerative diseases. I used to see a lot of Parkinson's patients and people with movement disorders, and those patients often showed up in the movement disorders clinic with depression first. Same thing with our Alzheimer's patients. And again, there is this marriage between mood and cognition, and the hippocampus and many more regions play a really important role in reading is somebody sad or depressed. And people who are chronically depressed with intractable depression have smaller hippocampi. And our patients with Alzheimer's disease have smaller hippocampi also. I don't know how you can quite separate the depression from the dementia in that way. So we do need to tease them apart and work with what came first. I don't know what comes first in many of our patients, but I remember one of my first patients in my integrative brain health program, as I called it after I worked with Dr. Bredesen. One of my first patients had an early Alzheimer's disease. And I remember her sitting there, and I have permission to talk about the patients who I'm going to talk to you about. I'm going to change some of their identities so confidentiality is respected and adhered to. But I remember this very beautiful and lovely woman in her 50s said, I just haven't ever been right since I lost my child. I've been in grief ever since. And that grief kind of just gradually, after 5 or 6 years of intense grief that wasn't treated, became a neurophysiologic, somatic, neuroanatomic situation that developed for many other contributing factors like Lyme and gut health issues, became a dementia. So that's when I talk about trauma as a root cause or unresolved emotional distress as root cause, I'm talking about it in that way, that there's a melange of things. So teasing them apart not only might help a person feel happier and freer and be better in relationships and get a sense of purpose in the world and feel better, it might also help their neurobiology and prevent, slow, or reverse a neurodegenerative problem that is just beginning.
Right. Yeah, so that's really well said. I think just to make sure everybody was tracking, what I picked up from that, and there was a lot, I think there were probably many other things that could be taken away from what you just said, but part of what I think is I try to put this in a simple model for my relatively simple mind. And, if you think about why someone might have a heart attack, right, there could be a few reasons, right? It could be too high of blood pressure. It could be too low of blood pressure. You could blow something out with too high of pressure. You could not have enough blood flow and therefore starve an area of the heart with not enough blood. You could have a blood clot or, obviously some type of plaque, which is the commonest. Just could and then why does that happen? Well, could be smoking, all the reasons, stress, etc. So there could be a number of reasons, sort of a number of pathways that would ultimately lead to, let's say, a dementia. So attentional issues, whereas sort of a neural network, nervous system, brain, if we will, brain derangement, or a depression that causes a kind of derangement, and of course, getting back to the kind of topic at hand, maybe trauma. Is there something about trauma itself may show up, as you said, in a few different, and maybe a few different categories, like the overly stimulated, the sort of sympathetic, and the flat, overly sort of parasympathetic. It sounds like we might be borrowing from Stephen Porges's polyvagal theory to some degree, but are there some classic kind of signs? Because we're a lot of times, at least from my vantage point, being in my 40s, there generationally, there's this sense of trauma. That's for the weak. It's for weak. We just sort of sucked it up, and we don't. I had all this stuff too, and we just got to powered through it. There's a survivor mentality, and perhaps there's a good argument to be made that generations before us were tougher and had to be tougher just to survive, and to now what we sort of take for granted. And so there was an aspect of evolution there that was what was required at the time. But now, as we kind of are able to look and say, okay, well, what are the kind of implications on the nervous system for that in a person that, let's say, 75, 78-year-old, 80-year-old person who is thinking, well, I know I don't have trauma. My childhood was good, or whatever. Are there certain indications to you? Because I'm thinking about our listeners, like, how would I know if I have trauma? Like, that was life. That's how it was. That's how it was down the street. That's how my neighbors were. That's how dads were then. They came home and they drank, and they, if they didn't like what we did, they got the switch out or whatever. And that's how it was in Pittsburgh when you got back from the factory, So I wonder if there are some clues to how an individual or somebody who's caring for or a partner of someone that is struggling cognitively, if there are some, I'm sure there's many signs, but there are some sort of classic or hallmark or things that make you say, there's probably some trauma here, and we have to explore that more. Like, what are some of the ways that this trauma kind of shows up in this group of people, if you will? How are you discerning that?
It's a very good question. And I think there's something that, from an evolutionary point of view, I think we're in a really different place right now. You and I, we're not in a position where we're looking for food. We're not in a war zone. I think we've become more aware of all kinds of inequalities and blind spots that we've had culturally here, but we're not suffering the way I know my grandparents suffered, and maybe your grandparents suffered too, where there was really no time to reflect. So I think that we're in a position now, you and I, and maybe some of the listeners, where there's time to reflect a little bit. People who are listening to this podcast are curious about where trauma or stress patterns might show up in their systems, or in the nervous systems of the people who they love and live with, whether they have dementia or not. And there are clues, and I think it's really patterns of behavior or patterns in posture that are clues for people. Maybe anger patterns. I think emotional dysregulation is a very big clue that someone has distress patterns. Like rage.
Other than just getting other than rage, is there, like, that's the one that I think probably first comes to mind.
Right.
Are there like going into hiding and not saying anything and sort of shutting down? I mean, there are others.
I like
clues?
that. Yeah, there's so many different patterns. I think the anxiety pattern is interesting because it's a combination of it's not an anger pattern necessarily, but it's an internal trembling. It's an internal, like nervous system jittering. And I always think of it as something needs to be released. And some of the newer views of trauma, like Peter Levine's model, and the basis of the development of somatic experiencing is based upon the knowing that animals in the wild had a chance to release their distress or release their threat and shake, for example, or move their bodies to release. So if an antelope was being chased by a lion and froze, and then the lion did not eat the antelope, when the antelope recovers, the antelope often shakes in the wild. Some of you might have seen the polar bear shivering video. That's right. Yeah. So I see that sometimes we hold in that tremor. We haven't, in our evolved way, we don't give the release an opportunity to move out of the body. So often I recommend all sorts of movement techniques for my patients. Some people do expressive dance. Some people do quieter forms of movement. mindfulness-based movements like yoga and different postures, and hold and become more aware of movement moving through their bodies in different ways. I see it as a trembling. Sometimes I see it as a rigidity. And maybe you talk about the collapse as a rigidity. You refer to kind of like, do people withdraw? I see people withdraw relationally when they have trauma. They become distant or cut off. And it's hard to approach and make social connection or engage socially. And so often what I do for my patients is attend to them and accompany them on whatever fear journey they're having because they have Alzheimer's disease, or whatever trauma unraveling journey they're on. And there's some kind of data to support what I'm saying right now, because in polyvagal theory, the evolved ventral vagus portion of the vagus nerve is really the social engagement network. And sometimes that withdrawal that we see in people is because they're wounded, and the way to engage them again is to engage that social engagement nervous system. So that's a big portion of what I do, in addition to the diagnostic work. And I think if clinicians are listening to this podcast, it's just to attend gracefully and kindly in a very spacious way with patients. And often there's not enough time. So I feel the luxury of having time with my patients is very important for healing trauma. But just the abiding with and accompanying, I'm sure, Nate, that you also see that is incredibly healing for people.
I'm actually surprised, and my wife actually had to point that out to me, because sometimes I just feel like, well, am I really helping this person? And they're telling us that they're helping, and on occasion, at least, as when the expectations, give me the pill or the shot or whatever it is that's going to fix me, when we don't have something like that. The presence and the listening and the being there, kind of with someone for the journey, is very powerful. And I was introduced to this term because you mentioned polyvagal theory. If people are more interested in that, there's all kinds of things you can read from Stephen Porges, podcasts and videos, and et cetera, et cetera. There's a wonderful book by Deb Dana, who's also a clinician. It's called Polyvagal Theory in Therapy. But there he raises a term because we want to just sort of turn our eye towards, for the last portion here of our conversation, towards solutions, right? What do we do about it, right? What do I do about it? Because maybe someone's in a situation where they don't have access to a functional medicine doctor or that kind of thing, or someone like you, and there's a term that is used now, and I don't know how long it's been used, but it's new to me: co-regulation, right? And so the way I think about this, in terms of this idea that polyvagal theory and much of what you've mentioned about trauma, where the nervous system sort of gets hijacked and then imprinted, right? And then it can express itself as rage, or the shutdown, or anxiety that you mentioned before, GI symptoms, and then all of the cognitive symptoms, right? And that's sort of I think you're helping us kind of, it now is occurring to us that one manifestation of unregulated or undealt with trauma is cognitive impairment. And when that continues to sort of continues on a path of deregulation, and it's untreated, it can be a significant contributor to development of Alzheimer's and other dementias potentially. And so then, okay, so now we got it identified. So what do I do? Okay, so I can go to someone and kind of talk about it. At the beginning of the conversation, and in some of our past communications, we've talked about, like you mentioned, embodiment, or other strategies. How do you now think about, okay, what can people do about it? Even for people that are further along and they're really starting to struggle with independence, and they're really losing the grip on the kind of normal life that they knew, if you will.
So I'm going to answer your question with another question. What's the first thing my patients, the first emotion that comes up is fear? Don't you find that?
Yeah, for 100%. Yeah, that
So,
long before they met me. Yeah.
oh my God, they are in so much fear. And so I'm going to just speak to embodiment right away, because when we're not aware of what's happening inside of our bodies, there's not much we can do. And embodiment is this felt sense of the body, and the body as an aspect of who we are, an important aspect of who we are. And there's all this neurologic wiring that's in place already in our brains and nervous systems to provide us with this feedback from what's going on in the body. And so being able to sustain or at least touch into that embodiment, even if it's just with a breath, a pause, and a simple breath, that's often where I start with people. My oldest patient is 96, and I just started with the breath. And most people, even at the end of their lives, don't have an awareness of their breath, even though we breathe so many times a day and we think so many thoughts a day. It surprises me how little awareness we have about, conscious awareness about our breathing and about our thinking. So I like to just slow things down. And one of the first things that I do with people I work with is to work on breath, self-awareness through breath work. We take something like 600 million breaths in a lifetime, but nobody really teaches us how to breathe, right, Nate?
Well, why
So
is it important? What does it do? You know what I'm saying? Because
yeah,
it is hard. At the end of the day, the most important thing is doing it. And then for some people, probably not everybody, but for some people, they won't do it unless they understand.
that's right.
Like they
That's
understand
right.
why.
That's right. Well, I've given you one good reason. Breathing allows us to feel more embodied. If you want to just try it right now, you can slow down the breath and slow down the whole process by just noticing the breath entering the nose. And that when breath enters the nose, it can just be a little bit cooler than when it enters the body. And if you watch the breath kind of go down through the body into the belly, and it's really good to kind of allow a noticing of the breath to go lower and lower and lower. So it really fills up the whole torso. Just that can improve focus and attention. It can engage a parasympathetic response, that rest and digest portion of the nervous system. So taking just 5 breaths, starting with noticing where the entry point of the breath is, and then letting it follow through all the way down to the belly. And I like to imagine that there's a balloon in my belly, even the color of the balloon. Choose a color of the balloon and expand that balloon. Allow it to open with the inhale and with the exhale, soften and contract. So being able to do some paced breathing, even 5 or 10 breaths, doesn't take long. It could take a minute or two. Can help improve focus and attention, can help regulate the nervous system, and can help us return to center. So it combines emotion and attention. So it's combining emotion and attention as a very easy tool to increase body awareness.
Amazing. Yeah, so it's an excellent starting point. There's all these kind of data on yoga. There's a little bit developing Tai Chi. There's go back with dance for a while. Like the Verghese paper in New England, or it was JAMA.
Yeah.
It was like 2003, and like there's more. We're just probably
So
getting
much.
a text from a student that we're working with, a neuroscientist student, that we want to publish a little intervention we've done in Kemper House in our one of the assisted livings where I'm affiliated with, and
Great.
and it's improvement on like memory scores, but really, the memory scores is just like a touch. We want to improve people's lives, like
Good.
so. Other things, there's this data, and we tend to think about it as like, oh, we're training the brain to sort of remember better, and you have to remember choreography, and that's somehow the key. I do think that that's probably part of it. You know what I mean? You have to kind of train the brain to do the work of, like heavy lifting. But you're suggesting, at least for the trauma component, that there are other strategies, or there are other things that people can do that may be helpful. Can you just sort of
There's so
give
many.
some of us some
Sure,
direction?
sure. And I want to hear more. I've just become interested in dance and memory. I know there's a
Yeah.
big literature on music. So just listening to music can be soothing and calming. Singing to music can be great because it engages a portion of the vagus nerve. So these are things people can do at home to calm themselves or center themselves. And they're easy things. Some of the things that I might mention today, I mean, actually, I'm not, there's so many things people can do at home that I'm not saying that everyone needs to see a psychotherapist. I think part of the reason I'm delighted to be speaking to you is because there are so many things people can do at home, like breath work, like dance, like singing, like exercise. And I like to break exercise down into different categories. Aerobic
Yeah.
exercise can really work with, we talked about that anxiety and that trembling feeling that people have in their bodies sometimes. Well, sometimes it is the need to release. Sometimes it is the need to complete a defenseless uh, fear response that they haven't actually completed. So, exercise, moving quickly, sweating, increasing heart rate kind of matches that anxiety response and conquers it. Going for a run. Now, not that going for a run isn't great for everybody who has cognitive decline, but it's certainly wonderful for people who are able to and want to have that release. Um, you mentioned Tai Chi, and in another category, I recommend that patients do one of these: yoga, Tai Chi, or Qigong.
Okay.
And that's because, again, there's a calm, embodied, and interoceptive, and I'll explain what I mean by interoception, awareness that happens with those three types of exercise that calm the nervous system. With those three types of exercise, we can calm down. We're still moving, but we're much more aware necessarily of what's happening on the internal realm of our body, what's happening, what communication we're getting from the internal somatic or visceral cues. And that's what interoception is. And it's a very important skill to develop. It's this bidirectional communication between bodily sensation and our cognition, our cortical kind of perspective. So those type of movements, yoga, tai chi, and qigong, really can enhance interoception, and it's great for emotional well-being, and it's good for cognition as well. There's some easy things like havening.
Like what?
Havening. Have you ever heard of the havening technique?
No.
Havening is I'm not. I want to give credit to the person who named it and developed it. I think it was developed by someone by the name of Dr. Rudin, and he understood this that bilateral sensory stimulation, touch, sound, had really promising results in dealing with trauma. And we know that bilateral sensory stimulation is important for healing trauma because we know that techniques like EMDR, which is a very strong, data driven, wonderful series of tools and techniques that I use with my patients, uses bilateral eye movements. Well, havening is a self-soothing technique, and you guys can't see me because we're on a podcast, but I'm putting my right arm, my right hand on my left shoulder, and my left hand on my right shoulder, and I'm just stroking down my arms really slowly at the same time or at different times, and I'm soothing myself. And this systematic movement, we can easily teach our patients to do this, but anyone who's listening to the podcast can easily do this as well. And it can bring, especially if you combine it with an image of someone or something very soothing to you or comforting, it can bring about a feeling of being very grounded, very calm, and very safe. So that's a very simple technique that you can do for a minute or two. You just cross your arms and stroke in a downward motion, and that's havening. So I'm happy I'm teaching you something, Nate.
Yeah, no, totally.
That's
That's
great.
great.
Um, Meditating, of course, but I call meditating more of a project. The first time you sit down and meditate, are you a meditator, Nate?
So honestly, I've done periods of meditation in my
Right,
life,
right.
and I have the kind of nervous system that is somewhat hyperactive and can
Right.
be, without a lot of work, can be inattentive.
Yeah.
And that's where my memory problems, that's how I sort of discovered. And then once, if you add a good bout, a good infusion of fear or anxiousness, so you can get completely discombobulated and have, instead of like a lot of trouble thinking. So
Yeah.
what we I've come to appreciate some of the sort of top-down approaches that you have to sort of go and see somebody like you have to go and see a psychologist, a therapist, uh, usually, to employ. And then some of these bottom-up approaches that are body-based, that
Yeah.
involve interoception, that in some cases probably are better done in a setting where you have a therapist there, especially exploring and a sort of
Support.
a dislodging trauma.
Mm-hmm.
But for people that are just sort of getting through day to day, some of the bottom up strategies, we're actually starting to kind of build an environment where we give people a combination, a couple hours of these strategies all together, where we include qigong, tai chi elements, um, uh, sort of multi-sensory information, sound frequencies, light frequencies, pulse frequencies in people's brains, plus cognitive tasks, right? In addition to, okay, we got to eat right, and got to do the rest of the matrix, as it was. But I think when we think that when and I'll know more in 3 to 6 months, but we think that when we can sort of combine these
Yeah.
together,
Mm-hmm.
we're more
Yeah.
likely to have a better outcome than if we only do one or the other, right? Or it's a sort of a both and approach. It takes time, and and I guess, we can talk about techniques all the time, but
Right.
that's another question for someone who's been doing this and working with people that are quite sick for a number of years. It's easy to think, oh, I got an idea, I'll tell you in 6 months, but
Yeah.
how long it takes a long time to change a nervous system. How long? What is for somebody who's been hijacked for 65 years or more, what is a reasonable amount of time to, let's say, the process of meditation? And of course, everybody's going to be a little bit
Well,
different, but how long does it take to kind of begin to see improvements and changes?
like a day.
Oh, well, that's pretty good.
Yeah. Yeah. I think you can see changes in a day with the interoceptive awareness, with the breath, with being guided. And I think it does take being accompanied. It just takes a moment flash to notice that you can connect with your own body and find a peaceful place. That's why I flippantly said a day, because I've seen people kind of relax with one intervention. That doesn't mean it holds, it doesn't mean it stays, but it means that a light bulb has gone off, and that person knows that there's a way they can intervene and find peace inside. And that's kind of the simplest answer I can give you.
Oh,
I'm really interested in, so the interventions that you're doing, you're combining, like you're pooling a number of interventions.
Yeah.
And how are you offering it to the inpatients or the
So,
residential?
so so it's called. We're just starting to advertise it. This is the first time I'll mention it on the podcast. It's called Brain Fit, and so it's 2 hours of direct cognitive training, um, plus physical exercise or body based practices that require both a cognitive load as well as a physical load. So we're trying top down,
Bottom up.
bottom up,
Good.
and in parallel, right? So sort of at the same time, and also seeing if we can add a little bit of energy through some fairly easy devices that are pretty accessible to anybody
Good.
at this right now.
Like laser
And
or
yeah, like lasers and direct current stimulation and that kind of thing. And we'll see.
Great.
So we have a little bit of pilot data from the Kemper House assisted living. It was hard because of COVID, and we could only work within the homes as opposed to with people in the community that were trying to stay
Sure,
out of an
sure.
assisted living,
Mm-hmm.
which is of course really we're trying to help everybody, but that's that's the main group of people that we're looking to try to help. And we saw with some real simple techniques. We saw some data. Again, it was an N of 4, so it's 4 people. We saw some data that was like, it's hard for me to believe, but that's why we collect the data. So so we don't have to believe or not believe. We can just look at the
data.
data, and then we talk to people. We talk to the individuals themselves, and then people that know them the best. And it was really from those comments from care partners that we were able to kind of get the next round of hypotheses of, okay, what seems like it's worthwhile to keep going after, and what should we keep and what should we ditch.
So what are some
So
of the
we'll see.
great? That sounds so great. You're packaging things, and so how many exposures of this package do the patients get,
So
and when? Yeah.
the more the better. I think the goal is 5 days a week. If when we're as when we're dealing with very, very damaged brains, if you will,
Uh-huh.
right? These are people that have are either on the border
Yeah.
of or already have lost some independence. We're way behind, right? They needed to be seeing somebody
A long time
25
ago.
years ago,
Mm-hmm.
and probably 20
Earlier
or
than that,
50, right?
exactly.
But here we are, right? And
Yeah.
here we are, and in order to get, I think, again, I'm not sure because we'll
Yeah.
see. But when I look at the reablement literature, which is a new term, and I didn't see until 2016
Yeah.
in literature, that most of the effective interventions are at least 3 months, usually 6 or longer, and are working usually 5 days a week. And so it's
That's
hard to
right.
get people to commit to that.
That's the issue.
But but at the same time,
Yeah. Why
what's
not?
the alternative
Why
here? Yeah,
not?
what's the alternative
Absolutely.
here?
But you're right, it is hard to get engagement. And I just want to clarify that when I was saying I see a change in a day or I see a change in an hour, what I meant was I don't see changes in people's cognition or changes in people's disease course. That I'm kind of laughing at myself right now.
Yeah,
What I see, though, is an ability to kind of say, okay, there's some agency here.
spark.
Even people who have anosognosia, and a lot of people who come to see you or me, this is really interesting. I've seen this several times. Patients who don't know that they have memory problems. You have patients who have anosognosia.
A few, yeah.
A few, yeah. Well, I've seen that change, which is kind of unusual with some of the interventions you're talking about. I've seen that change where people, and that's really important because people who are not aware that they have memory problems are not engaged and are not interested, and then the caregiver has to do all the work, and those caregivers burn out, so that doesn't work.
Totally.
So being able to
I
change
have
that.
seen that in TBI. I've seen that in traumatic
Yes,
brain
yes,
injury, I have
yes.
to say,
Oh,
where
good.
people,
Me too.
as they start to get better,
Yeah,
they start to notice how impaired they are. That's really interesting.
that's true. And I've seen it in
Really interesting.
Alzheimer's again. I haven't seen that in the literature. Maybe they haven't looked for it actually. So,
Fascinating.
yeah, I'm excited about what you're doing. I think
Thank
it's
you.
share
I
more
want to
with me
ask
at
you,
another time. Yeah,
when we have more information to share, I'm excited to share. I'm excited to share. I know we really have to wrap. We try to keep these interviews to an hour.
good.
I did want to ask you. I know that you've at least I've heard that you've been engaged in a research project during this whole pandemic with an international group of researchers. Stress, coping strategies. Have you found anything interesting so far?
So the data is so beautiful. It's something I do on my weekends. But the group is called Disaster Shock, and they develop trauma-informed strategies to help people cope with the disasters all over the world. And we thought, this pandemic certainly is a disaster. Why don't we gather some data? So over the last year and a half, I think we have data from about 12 countries. And we asked people, we had a survey and asked people how they coped with the best stress reducing strategies for them. And by and large, we found incredibly simple solutions that help people cope with stress. It was connection, either online or in person. So social connection, that calmed stress, and that sort of goes along with all the things that we talked about today.
Yes.
Social connection, coherence with another person, co-regulation was the word you used. The other thing that was really helpful were creative projects, craft projects. I don't think people do many craft projects when they're not at home. I mean, you have to be at home to do your craft projects. So people were engaging in craft projects. And the other thing was walking. And I thought walking is really such a good medicine for people. And you and I are probably always trying to get our patients moving, not just for anxiety reduction, but all the data we know on how beneficial walking is for cognitive health and Alzheimer's disease and other neurodegenerative illnesses. So,
100%.
Yeah, you and I didn't have a chance to talk about building cognitive strength, and I love that you're combining bottom-up techniques with top-down techniques. But I think it's really important that patients develop a routine. And if they're not in your program or they're not in my program, it's really important that people link one of these calming or soothing strategies for their nervous system to an activity that they do every day, whether that's in the morning or at night before they go to bed. I have a lot of resources on my website, which is IleneNaomiRusk.com, my name, or Dr._Rusk. I provide a lot of free resources for people to help with their nervous system, release trauma, and use a functional medicine approach to address neurodegenerative disease like Alzheimer's. But so linking this to particular routines in the day is really important, Nate. So that's an important takeaway. Do activities which are engaging and stimulating and meaningful to you, and make sure that if there's a care partner or caregiver involved, that they are equally engaged and enthusiastic about the activity, whether it's learning a language or finding out more about something you've been curious about your whole life. Linking that with the physical exercise. That's a simple way to do your program at home and combine a top-down with bottom-up technique, a cognitive with a somatic engagement technique. So I hope that answers your question.
It totally does. And it's even more helpful to have the link. Ilene Naomi Rusk will, of course, post that in the show notes for a lot more tools and strategies. Thank you for your time. Thank you for the wisdom. And I hope to talk again soon.
I do too. Congratulations on that incredible work you're doing. And I love talking to you too, Nate. Talk to you soon.
So that's our episode. I hope it was useful to you. Check out the show notes on iTunes or on our website where we've summarized key points. If you find the information here valuable, please consider giving us a 5-star rating on iTunes and leaving comments in the comments section. It will really help us bring this message to as many people as we can. If you have questions or comments, connect with us on social media. Finally, to support us, go to patreon.com/evolvingpast and consider hitting the button and becoming a patron of this show. That's Patreon, Patreon, patreon.com/evolvingpast. Thanks. We'll talk to you next time.